Hi, I'm David Olive. I'm an anaesthetist at the Royal Victorian Eye and Ear Hospital. This short film aims to teach Sub Tenons blocks, an anaesthetic technique for eye surgery. To assist in getting the optimum camera angles, the footage was taken from a handful of different patients, all having Sub Tenons blocks for cataract surgery. A Sub Tenons block is an alternative to sharp needle techniques such as a retro or peribulbar block. Trainee anaesthetists should aim to be adept at all types of blocks. More experienced anaesthetists may already be very adept at sharp needle techniques. However, even if a Sub Tenons block was not going to be your default technique, you may find it a useful string to your bow in certain circumstances. This diagram shows the relevant anatomy. The block involves the deposition of local anaesthetic into the subtenon space, a space between the sclera and Tenons capsule. Tenons capsule is a membrane that encloses the globe between the sclera and the conjunctiva. It fuses with the conjunctiva near the limbus and with the dura surrounding the optic nerve posteriorly. It is penetrated by the extraocular muscles as they insert into the globe. The indications and contraindications for a Sub Tenons block are largely relative. Relative indications include a very long eye where the risk of a globe perforation may be increased, or a patient taking clopidogrel or other powerful anti-clotting drugs where the risk of a retrobulbar hemorrhage may be more significant. Relative contraindications include trabeculectomy surgery, the theoretical concern being that a Sub Tenons block may lead to conjunctival inflammation, which may decrease the success of the surgery. Also, a scleral buckle may limit access to the posterior subtenon space. A bloodshot eye or an infranasal pterygium, which may be quite vascular, can lead to excessive conjunctival hemorrhage and a very red eye and a poor cosmetic result. A horrible looking red eye should never be accepted as an inevitable consequence of a Sub Tenons block, as it can usually be avoided or at least minimised. Here's the equipment that you'll need to perform a Sub Tenons block. At the Eye and Ear we have pre-prepared Sub Tenons kits. These kits contain an eyelid speculum, a pair of Moorfields forceps, these are non-toothed forceps, and a pair of Westcott spring scissors. In addition to this, you'll need a Sub Tenons cannula. We use a 25mm 19 gauge Stevens style cannula. This means that the distal portion of the cannula has a flattened cross section. Preparation for a Sub Tenons block is similar to that for any eye block. Instill local anaesthetic drops early in the piece. I instill these into the infranasal quadrant rather than directly onto the cornea for greater patient comfort. Insert an intravenous cannula and attach a saturation probe for monitoring. You can use whichever sedation is your preference. Bear in mind, however, that this is a technique in which patient cooperation is very useful in order that the patient can look in the direction that you want them to look. The patient has received topical anaesthetic drops with binoxonate or oxybuprocaine, and then antiseptic in the form of a betadine swab is applied. Open your eyes. Sometimes when you swab with these, the bottom eyelid misses out on the antiseptic, so I just ask the patient to look up and then apply some antiseptic to make sure that I get the bottom eyelid, and also that I have some antiseptic in the conjunctival sac, which you can see that I have. I use a mixture of lignocaine, ropivacaine and hyaluronidase and draw up 5 mL for each patient. I then attach the Sub Tenons cannula. I ensure that the curve of the needle is pointing away from the numbers on the barrel of the syringe. This way I know the orientation of the curve while performing the block. I prefer to have the needle then only loosely sheathed so that while performing the block I can pick it up one-handed. For a right-handed anaesthetist, it's easiest to sit at the head of the bed to block the right eye, or on the patient's left to block the left eye. Insert the speculum by asking the patient to look in the opposite direction to the lid under which you're about to insert the speculum. Don't press against the first lid when inserting the speculum under the second. Ask the patient to look up and out, and sometimes then rotating the speculum better exposes the infranasal quadrant. Have both hands resting on the patient to minimise any tremor. I prefer to sit. We tend to use the infranasal quadrant for a Sub Tenons block for a few reasons. One is that there are no muscle insertions there. Between medial rectus and inferior rectus there are no muscle insertions. In the other quadrants you have the oblique muscles, here and here. Also, infranasally, the surgeons very rarely use that quadrant for their approach because they can't get into a coronal plane given the nose. So it's a useful quadrant for us to use. George, look across towards me and up towards my shoulder. Try to get a reasonable distance away from the limbus so that any redness from your cut is going to be covered by the bottom eyelid. Don't get so far away from the limbus that you get into this fatty tissue of the bottom eyelid because that will cause a lot of bleeding. So here I'll just get down about there. There is a blood vessel there. I'll try and move away from that. Push into the globe slightly with your forceps before you pick up, and that way you'll get both Tenons capsule and conjunctiva. And now pick up. With your scissors, ensure that you come in perpendicular to the surface of the globe. Don't come in flat like this. Come in perpendicular and try to have your cut heading radially out from the globe, not sideways like this, but radially like that. I push in with the scissors and make a little incision, and we can see now the white of the eye is much whiter when you see sclera with no overlying conjunctiva. So this little patch here is bare sclera compared to out here, which is sclera covered by conjunctiva. So now I go into this layer with the scissors closed at all times and dissect around posteriorly, and there I just felt a little bit of loss of resistance as I passed through the adhesions at the equator of the globe. At all times now I leave my forceps resting on the globe, not lifting up. Pick it up, I brace myself against the patient's head with my little finger and pass this into the incision that I've made, and now come around to almost vertical and inject the local anaesthetic posteriorly. I rotate the barrel of the syringe along its long axis to spread the local anaesthetic posteriorly and put in about 4 mils. Well done, George, just about finished. If I can just point out the site of my incision is covered by the lower eyelid. I think a good cosmetic result is something that is not the be-all end-all, but I think it is important, and we should try and make the eye look good afterwards. So you can, if I pull down, you can see down about here is where I made my incision, and in fact it's a little bit covered by redundant layers of tissue here, but that all gets covered up completely when the eye returns to the neutral gaze, and so I don't end up with a red eye. Note the vertical scissors. Scissors brought in horizontally will cause an arcuate incision. A flap of conjunctiva on the concavity of the arc may fold in and cause an inclusion cyst. When inserting your cannula, follow the contour of the globe by bringing the syringe up to almost vertical, rather than heading off on a tangent, which can cause pain. Apply gentle pressure to the incision point for a couple of minutes after the block. Could I get you to look up over your head, and look across towards me a little bit. Look across to me. That's better. So here I don't have fabulous patient cooperation, so sometimes I can just pull the globe with my closed scissors away from the eyelid and then pick up like that. Look across to me, Jennifer. And there I just felt that loss of resistance. And there you can see the difference in colour. So you can actually see the plane that I've got into. And now again note how my forceps are resting on the patient's globe. I never lift them up off the globe, which creates a big tear. I then again rest my hand with the syringe against the patient, and now I have both hands resting on the patient and the shaft of the needle resting against the forceps. So there's no tremor, everything's quite stable, and I start to inject. In this occasion I've got a little bit of resistance to injection, so what you do there is open up the potential space posteriorly by coming up vertical, push against the globe and lift, as if you're trying to lift the globe towards the ceiling. And then all of a sudden, almost finished, Jennifer. The patient sometimes has some slight discomfort there. All of a sudden you get a loss of resistance and I'm able to inject. The onset of a Sub Tenons block is very quick, so you can move into theatre within a couple of minutes of performing the block, and the technique is quite suitable for a busy eye list.